Hey folks, welcome to episode 6 of the Appalachian Roundup. We're going to talk about healthcare in Appalachia and why it's in the dumps. Stay with me. So, we're going to start out with a quick review of this book, Mask, Misinformation, and Making Do Appalachian Healthcare Workers in the COVID-19 Pandemic. It's edited by Wendy Welch, and she is the executive director of the Southwest Virginia Graduate Medical Education Consortium. The book basically is about 19 chapters, and it covers it's written from healthcare providers' perspective, and it is basically talking about their experience during COVID, both in terms of what it was like to deal with patients, what it was like to deal with the government, what it was like to deal with market situations. And it's published by Ohio University Press, and it's free. You can actually get a free copy. I'll have the link down below. The book covers a number of different issues, and covers a number of different personal experiences. For example, a nurse in Lee County, Virginia, worked without an N95 mask for 4 days due to a shortage in the hospital. And there's a chapter on how her experience doing that as a pregnant woman. There's a chapter about how, for example, women in the communities work together to sew masks. There's also chapters on racism, black patients in Appalachia, the skepticism that they felt going to be treated by white doctors. And on the flip side, black nurses and black doctors, how they experienced racism and skepticism and all sorts of things in trying to treat patients who are sick. There's a really interesting chapter on resistance to care in Appalachia and the ways that people turn to either religion or a sense of fatalism, rather than actually trying to just use science or basic medical information to deal with the illness, that there were these ways that people kind of avoided actually treating themselves. So there's a great section on the historical background of the development of a healthcare system in the United States, but in Appalachia in particular. And that chapter, I think, does a very good job of highlighting how the healthcare system and the system of hospitals and its organization around certain market principles of, say, things like efficiency have created these problems in terms of being able to staff or being able to provide affordable care. The foreword is also very interesting. It's written by Alan Morgan. He's the CEO of the Rural National Health Association. He makes a number of points that are relevant in a short foreword. Two I want to highlight is that national efforts to create an efficient healthcare system have also created a nationwide system of care poorly positioned for pandemic surge capacity. Rural communities, long struggling with workforce shortages, find themselves now competing nationally for the recruitment and retention of key healthcare staff at a level and magnitude not seen before. He says that we're entering a period in terms of workforce shortages in the healthcare industry in particular, that are destructive in terms of the system. He's looking at rural America more generally, and the book is about Appalachia in particular. So one relevant part that he says here, I think, is directly related to Appalachia. Therefore, the story of rural America during the COVID-19 pandemic is best examined by looking at the response of an under-resourced and poorly designed system of care, providing care for a population most at risk for the pandemic. And basically, the larger point he's getting at is that there are some serious problems here. He highlights like, for example, the use of telehealth as a positive way that doctors and healthcare providers within Appalachia were able to address concerns, and telehealth is something that's expanded. But the overarching message is that the healthcare system is ultimately unsustainable, given that its design is focused on efficiency. I want to think about a particular part of it. My experience most is with Southwest Virginia and Northeast Tennessee, and that is largely controlled by Ballot Health. What is Ballot Health? Was the outcome of a merger between two already existing healthcare systems in Northeast Tennessee and Southwest Virginia. They merged in 2018 and formed Ballot Health, and Ballot now serves 29 counties in Northeast Tennessee, Southwest Virginia, Northwestern North Carolina, and a little bit of Kentucky, Eastern Kentucky. And at the time when Ballad was proposing to merge, there was a lot of criticism about the proposal because of fear that it would basically, this merger would create a monopoly. And the fear was that a monopoly would lower quality of care and raise prices. And Ballad basically assured all of the stakeholders that that problem would not occur, and that Ballad would aggressively investing in care and facilities and so forth, so that the quality would not decline and the costs would not increase. In order for this merger to happen, it committed to keeping hospitals open and maintaining essential services in every county that it served. It experienced a financial loss of something like $36 million in the third quarter of 2022. The leadership, Alan Levine, the CEO of Ballad, says that Ballad is no different than other hospitals in that they're all losing money in this time period. One of the main issues, according to Levine, that plagues Ballad is staff shortages are the primary problem that they face. Recently, Ballad Health's credit rating remained an A, and so the credit agencies, Fitch's, was now, according to Ballad, Ballad Health hospitals receive national recognition for high quality and patient safety. But on the other hand, I know personal experiences at Ballad, the rumor mill about Ballad, as well as like looking at other reviews like in the Better Business Bureau. People's trust and opinion toward Ballad, who are in the service area, is pretty low. For example, take the Johnson City Medical Center, which is the flagship of the Ballad Health system in Johnson City, Tennessee. It has a D rating in terms of hospital safety. It has to do with things like infection, infection of the blood, infection in the urinary tract, surgical site infection after colon surgery. All of those fall within the red range. Sepsis, infection after surgery. So all of these things kind of fall within this range and illustrate a pretty scary situation in terms of care. So you're kind of getting this picture where on one hand, their credit rating is good. They might be losing money during the quarter, but overall their credit rating is clearly good. Fitch's thinks that they have a high rating. But on the other hand, people's healthcare experiences, the evaluations, the Better Business Bureau ratings all point to like a two thumbs down kind of situation here. And so in terms of care and people's perception of the care they're receiving, it looks like it's pretty trash. But on the other hand, it's making good money. How does that work? What holds that together? I think one of the key kind of things here, certainly in terms of is the leadership. Alan Levine is infamous or famous because he appeared in a 60 Minutes healthcare expose about more than a decade ago when he was in Broward County in a hospital system in Florida. There, he was basically a spokesman or part of the leadership team. They were being investigated by 60 Minutes for their profit-making practices. Now, Alan Levine is the head of Ballad Health. So I'm imagining that he's running Ballad Health in much the same way as he ran or was part of the leadership team down in Florida. So it's a pretty dire situation. I mean, you have a monopoly healthcare system in the region that provides, at least in terms of the patients perceived, low quality D and F and C level care. But in terms of the financial evaluation of the hospital, it's seen as like profitable, as a good investment. I mean, there's some clear divides here, and I'm thinking about what helps explain this situation. And so I would say Ballad is part and parcel of what's been going on, particularly since the 90s, especially, let's say, in the 2000s, when you have privatization and consolidation of healthcare systems, again, across the United States. But it's also an example of what's called regulatory capture. And And by this I mean the monopoly. People opposed the monopoly because it would lower quality of care. But the Tennessee legislature intervened and created what they called the Certificate of Public Advantage, which the COPA, and this is now is being very controversial, but at the time the COPA was a way for them to like get over the fact that monopolies would undermine care, raise prices. But now it looks like the COPA has come to bite them in the ass. But it also, the outcome has been by this monopolization, limited care. There are any number of examples, both rumor and in my firsthand experience talking with doctors in Southwest Virginia, particularly around the Abingdon area, that they could not expand their offices or had trouble opening their offices because of the non-compete clauses that Ballard tried to get people to sign into, again, to enforce a monopoly. But all of this really comes back to and reminds me of this great, fantastic book called Deer Hunting with Jesus by Joe Badgent. And he's talking about healthcare in rural America, but he's from Winchester, Virginia, but he's talking about healthcare in Appalachian and rural America. But in one chapter called An Authorized Place to Die, he is talking about healthcare in particular. And I just, when I was thinking about this whole situation with Ballard and what's going on, thought about this chapter. And it says that he refers to these as false nonprofit hospital networks. They followed what he says is the complete destruction of the public healthcare system in the United States. It was the HMOs that put the death knell in the public healthcare system, HMO system. He says here, this was accompanied by the nearly complete destruction of the public hospital systems and health clinics by HMOs and Bush administration funding cuts, and by the rise of false nonprofit hospital networks. He goes on to sort of highlight how these nonprofit hospital networks wield tremendous power, monopoly-wielding power within particular regions, like in Appalachia, like in Ballard Health's case here in Southwest Virginia, Northeast Tennessee. He makes this funny quip that nonprofits are more profitable than for-profit businesses. He just goes into critique on all these various things, like how these hospitals don't perform many of the functions that you would expect nonprofits to perform. They are run like corporations. They get all these tax exemptions from the government and then go around taking the revenue they're generating and reinvesting it, which is sort of gobbling up all of the healthcare competition in the surrounding area, which is precisely what Ballard has done. When Ballard moved in, it basically started creating these healthcare centers, wellness centers, and all of these other things. Again, buying up land. The revenue is used to expand this behemoth. And so you have this situation where the healthcare provider, as a monopoly, nonprofit monopoly, just kind of like expands out and gobbles up land, becoming a large corporate multi-million dollar, is supposed to be providing healthcare, but in many instances does not provide good health care, or provides health care that's subpar, or ends up you getting killed or dying. So that's the situation in terms of Appalachia. And again, like when we put people like Alan Levine in charge of these organizations, and we form these organizations around the idea of generating revenue over providing care or public care or the public good, then we create a situation like this where healthcare has become a commodity that's inaccessible for many people, millions of people throughout Appalachia, throughout the United States. So if you're thinking about like the situation in terms of Appalachian healthcare, both in terms of COVID-19 or just in general, and these two books connect together and talk and speak together, both kind of shed light on the problem of healthcare and how it's fucked up. I hope you enjoyed the conversation, and I'll see you here next time.